Image analysis of the chest with Brandy Jones. The agenda for the chest projections are PA and lateral, AP stretcher chest, apical chest, obliques, decubitus, right and left. The diagram on the left is the labeled thorax. It'll help you identify your anatomy. The x-ray on the right, I would like you to try to count the ribs. So you can see all 12 ribs really well here. The ninth rib is right at the diaphragm on the right side. 1 and 2, the first and second ribs are a little hard to determine. So the patient might be slightly kyphotic or maybe slightly leaning a little too far forward. However, has anybody noticed anything with this x-ray? Any kind of artifact? The patient was wearing a polo shirt, and you can see the collar really thick in the neck and the apice area. This is the same x-ray. This is just blown up a little bit so you can see the first, second, third, fourth, and fifth ribs a little easier so you can see how to count. With that being the patient's shoulders being a little bit superimposed, as you can see how 1 and 2 are directly over top each other. Anatomy. All anatomy is important to know, whether it is skeletal and or organ. So why is it important to know your anatomy? Well, sometimes the body's going to play tricks on you. The normal anatomy, the liver is normally under the right hemidiaphragm, as seen on this picture on the right, and the stomach bubble and spleen are seen on the left side. Heart anatomy. It is extremely important to know your heart anatomy. This is an excellent diagram for you to get to know. A lot of lines are placed in the superior vena cava, and you can see the placement here where it is. Situs inversus totalis is a rare congenital abnormality characterized by a mirror image transportation of both the abdominal and thoracic and heart, which is why you really need to know your anatomy. A lot of times the doctor will request a second x-ray to prove the anatomy is actually the situs inversus and not a tech error. So try to pay attention to your anatomy so you can catch it and double, triple check your marker, your positioning before your patient even moves or leaves from the chest board. Chest PA projection. Chest PA projection. The proper patient positioning for PA chest projection shows the light field with the central ray entering mid-sagittal plane in T7. On the right, the X-ray, the PA chest projection with accurate positioning. Chest PA projection image analysis criteria. Both lungs from apices to costophrenic angles should be seen. The chin should be elevated out of the apices or the exposure field. T7 should be in the center of the exposure field. The scapula should be out of the lung field with the shoulders rolled forward. The clavicles are positioned on the same horizontal plane, so therefore the shoulders should be depressed. No rotation should be seen. Both sternoclavicular joints should be equidistant from the midline. The distance from the lateral rib margin to the vertebral column are equidistant. A minimum of 10 posterior ribs visualized above the diaphragm per Bontrager's. Now, it says 9 ribs with your image analysis textbook. So slight differences there. No motion evident by sharp outlines of the rib margins, heart borders, sharp lung markings in the hilar region. So you should see the spine through the heart shadow, long scale contrast, and the manubrium should be superimposed by T4 on all of the chest x-rays. Chest is demonstrated without foreshortening, and 1 inch of the apical lung field is visible above the clavicles. Evaluate PA chest number 1. Evaluating PA chest number 1. Analysis. The manubrium is situated at the level of T3. Less than 1 inch of the apices is demonstrated superior to the clavicles. The upper mid-coronal plane was tilted posteriorly. The diaphragm is superior to the 10th posterior rib on the right side. The projection was obtained without full inspiration. Correction. Move the patient's upper thorax towards the IR until the mid-coronal plane is parallel with the IR. Coax the patient into taking a deeper inspiration. Make sure that you are taking the exposure on the second full inspiration. Posterior mid-coronal plane tilting. If the superior mid-coronal plane is tilted posteriorly, as demonstrated in this image, the lungs and heart are foreshadowed. The manubrium is situated at the level above the 4th thoracic vertebrae, and less than 1 inch of the apices is demonstrated above the clavicles. Evaluate PA chest number 2. Analysis practice of PA chest number 2. Analysis. The manubrium is situated at the level of T5. More than 1 inch of the apices is demonstrated superior to the clavicles. The upper mid-coronal plane was tilted anteriorly. Correction. Move the patient's upper thorax away from the IR until the mid-coronal plane is vertical. Anterior mid-coronal plane tilting. If the superior mid-coronal plane is tilted anteriorly, as demonstrated in this picture, the lungs and the heart are foreshortened. The manubrium is situated at the level of T5 or lower, and more than 1 inch of the apices is demonstrated above the clavicles. The positioning error often occurs during imaging of women with pendulous breasts and patients with protruding abdomens. Evaluate PA chest number 3. Evaluating PA chest number 3. Analysis. The right sternoclavicular end is demonstrated farther from the vertebral column than the left. The right side of the chest was situated farther from the IR than the left side. The scapula are in the lung fields. Correction. Rotate the right side of the chest towards the IR until the mid-coronal plane is parallel with the IR, and protract the shoulders by placing the back of the patient's hand on the hips and rotating the elbows and shoulders anteriorly. Chest rotation. How do we look for rotation? Evaluating the distances between the vertebral column and the sternal ends of the clavicles, comparing the lengths of the posterior ribs. Distance from the lateral rib margin to the vertebral column are equidistant. What happens to the rotated PA chest? A rotated chest demonstrates distorted mediastinal structures and creates an uneven brightness between the lateral borders of the chest. The brightness difference occurs because the X-ray beam traveled through less tissue on the chest side positioned away from the IR than on the side positioned closer to the IR. It may be detected when the chest has been rotated as little as 2 or 3 degrees. Because any variation in structural relationships or image brightness may represent a pathological condition, the importance of providing a non-rotated PA chest projection cannot be overemphasized. Clavicles. The lateral ends of the clavicles are to be positioned on the same horizontal plane as the medial ends by depressing the shoulders. Accurate clavicle positioning lowers the lateral clavicles by depressing the shoulders. The middle to the lateral clavicles will be placed away from the apical chest region, providing better visualization of the apical long field. When a PA chest projection is taken without depression of the shoulders, the lateral ends of the clavicles are elevated, causing the middle and the lateral clavicles to be demonstrated within the apical chest region. This image is a PA chest taken with elevated shoulders. Scapula. If a chest projection is taken without one or both of the shoulders adequately protracted, the scapula will superimpose over the lung. Scapular densities may prevent detection of abnormalities in the periphery of the lungs. When the scapula are accurately positioned outside the lung field by rolling the elbows and shoulders anteriorly, the superlateral portions of the lungs are seen without scapular superimposition. Chest, lateral projection, left lateral position. Chest, lateral projection, left lateral position. Here is an example of proper patient positioning for the lateral chest. The picture is actually off. The mid-coronal plane is slightly anterior. I have placed a marker on the mid-coronal plane so you can see the better centering. Sometimes your textbooks aren't always correct. Lateral chest projection with accurate positioning seen here on the labeled image. Chest lateral image analysis criteria. The entire lungs from the apices to costophrenic angles and from the sternum to the posterior ribs is present. The chin is elevated and out of the apices. No rotation evident by posterior ribs and sternum. The right and left side of the posterior ribs are nearly superimposed, demonstrating no more than a ½ inch of space between them. The sternum should be in profile. The hilar region should be in the center of the IR. The midcoronal plane at the level of the athoracic vertebrae is at the center of the exposure field. No motion should be present, evident by sharp outlines of the diaphragm and lung markings. Visualization of the rib outlines and lung markings through the heart shadow and upper lung areas without overexposing regions of the lungs. A long scale contrast should be used. Evaluate lateral chest number 1. Evaluating lateral chest number 1. The right and left posterior ribs are separated by more than a ½ inch. The chest was rotated. The patient was positioned with the left thorax rotated anteriorly and the right thorax rotated posteriorly. The humeral soft tissue shadows are obscuring the anterior lung apices. Correction. Position the right thorax anteriorly. The amount of movement should be half of the distance between the posterior ribs. Raise the arms until the humeri are vertical, removing them from the exposure field. Rotation can be detected on a lateral chest by focusing on what? The sternum and posterior ribs in the spine. For rotation, look at the posterior ribs on the right side that is magnified is closer or far away. Magnified is further away. So the image, the right side is more posterior and further away. Mid-sagittal plane tilting and lung foreshortening. To obtain a lateral chest without lung foreshortening, the mid-sagittal plane is aligned parallel with the IR. When imaging a patient with broad shoulders and narrow hips, it may be necessary to place the hips away from the IR to maintain a parallel mid-sagittal plane. When the mid-sagittal plane has not been positioned parallel with the IR, lung foreshortening and poor hemidiaphragm positioning will occur. Evaluate lateral chest number 2. Evaluating lateral chest number 2. Analysis. The hemidiaphragms are not superimposed. Correction. Check the PA projection carefully. Determine whether the diaphragms are at the same height or whether a pathological condition might have caused one diaphragm to be projected above the other. If no such condition is evident, shift the patient's hips away from the IR until the mid-sagittal plane is parallel with the IR before repeating the projection. Before repeating a lateral chest because of poor hemidiaphragm alignment, scrutinize the accompanying PA projection to determine whether or not the PA projection is one of the 10% of those whose hemidiaphragms are at the same height or whether the pathological condition is causing the left hemidiaphragm to be projected above the right. Evaluate lateral chest number 3. Evaluating lateral chest number 3. Analysis. The humeri and the soft tissue artifact in the anterior chest and apices. Correction. Raise the arms higher above the head. Chest. AP projection, stretcher, or with portable X-ray. Chest, AP projection, supine or with portable. Proper patient positioning for an AP chest projection seen in the image on the left. A labeled diagram with anatomy and accurate positioning is on the right. Chest, AP projection of image analysis criteria. Elevate the chin out of the collimated field. Move the arms and any movable leads or wires outside the collimated field. No rotation. Lung fields demonstrated symmetry and demonstrate without foreshortening. Distances from the vertebral column to the sternoclavicular ends are equal. Lengths of the right and left corresponding posterior ribs are equal. T7 is in the center of the exposure field. Thoracic vertebrae and posterior ribs are faintly seen through the heart and mediastinal structures. Clavicles are positioned at the same horizontal plane. The manubrium superimposes T4. 1 inch of apical lung field should be seen above the clavicles. At least 9 posterior ribs are visualized above the diaphragm. Chest, AP projection, image analysis criteria, similar to the PA with 3 exceptions. The heart, 1. The heart appears larger as a result of the increased magnification from a shorter SID and an increased OID. 2. Without a horizontal beam, fluid levels may not be visible, so always sit your patient erect as possible. 3. Inspiration is usually not as full. Usually 8 to 9 posterior ribs are seen above the diaphragm. Chest rotation side to side. To prevent chest rotation, align the transverse axis of the IR mid-coronal plane parallel with the bed. On beds with special padding, it may be necessary to place positioning aids to help level it. This is best judged by observing from behind the X-ray tube, looking straight at the patient. Poor side to side CR alignment projects the manubrium of the clavicles in the direction that the CR is angled, causing the manubrium and sternal ends of the clavicles to be situated more towards the right or left side of the vertebral column, and rotation is to be demonstrated. This is an AP chest taken with a CR angle towards the left side, causing the resulting projection to be demonstrated rotation. Excessive caudal CR angulation. For accurate alignment of this anatomy, position the CR perpendicular to the longitudinal axis of the IR mid-coronal plane. Inaccurate cephalic caudal CR angulation misaligns this anatomy and distorts the heart and lung structures. The anatomic structures positioned farthest from the IR will move the greatest distance when the CR is aligned. So aligning the CR too caudally for an AP chest projection moves the manubrium inferior to the fourth vertebrae, demonstrating more than 1 inch of long apices superior to the clavicles, and changes the posterior rib contour to vertical. A caudal angle also elongates the heart and lung structures. The cephalic caudal alignment of the CR with respect to the patient determines the relationship of the manubrium to the thoracic vertebrae. The amount of apical lung field seen above the clavicles and the contour of the posterior ribs. Excessive cephalic CR angulation, angling the CR too cephalically for the AP chest projection, projects the manubrium superior to T4, demonstrating less than 1 inch of lung apices superior to the clavicles, and changes the posterior rib contour to horizontal. A cephalic angle foreshortens the heart and lung structures. The more the CR angulation is mispositioned, either caudally or cephalically, the more distorted the anatomy. Positioning for the supine patient. For the supine AP chest projection, the patient's kyphotic thoracic vertebrae are forced to be extended slightly, straightening because of the body weight of the gravitational pull on them. This straightening causes the anterior thoracic cage within the manubrium clavicles to move superiorly. The results in the projection demonstrating less than 1 inch of apical along field superior to the clavicles. place a 5-degree angle on the CR can offset this. Always make sure you guys are angling to the angle of your sternum. Central line placement. Here is a picture of what the central line placement is doing. It is going down into the SVC of the heart. One of the most common reasons for portable chest X-rays as well as ET tube placement. It's important to know the lines and where they should be located. I have given you guys a handout for you guys to keep and know for all kinds of lines. It's important, and I think you guys should know it. We don't really go over those just yet until the fall, but I thought this would be a perfect time for you guys to start experiencing and getting to know these lines. So keep it with you, put in your black book. Evaluate AP chest portable number 1. Evaluation of AP chest portable number 1. Analysis. The manubrium is superimposed over the third thoracic vertebrae. Less than 1 inch of the apical lung field is visible above the clavicles. The posterior rib demonstrate a horizontal contour. The CR was angled cephalically. Correction. Adjust the CR angulation caudally until it is aligned perpendicular to the mid-coronal plane. Evaluate AP chest portable number 2. Evaluating AP chest portable number 2. Analysis. The manubrium is inferior to the fourth thoracic vertebrae. More than 1 inch of lung if apices is demonstrated superior to the clavicles. The CR was angled too caudally. The lateral clavicular ends are superior to the medial clavicular ends. The shoulders were elevated. Correction. Adjust the CR angulation cephalically until it is aligned with perpendicular to the mid-coronal plane and depress the shoulders. Evaluate AP chest portable number 3. Evaluating AP chest portable number 3. Analysis. Uneven collimated borders are evaluated in the tube part IR alignment. Clavicles are projected in the top portion of the apices. Correction. Requires more of a caudal angle. Need to see 1 inch of lung above the clavicle. Check the tube angle from side to side. Remove the leads, or at least move the leads to the sides. And make sure you get all the anatomy included. The left angle is cut. Chest, AP axial projection, lordotic position. Chest, AP axial projection, lordotic position. Here is a good example of AP axial lordotic chest projection with accurate positioning. The X-ray that they have here is a little different. So in one book, you guys are required to get just the top portion, and in Bontrager's, you are required to get the entire lung. You are, by ARRT, required to get the entire lung. The apical lordotic image analysis criteria. Entire lung fields and clavicles. Clavicles should appear nearly horizontal and above or superior to the apices. The medial aspects of the clavicles superimpose the first rib. Ribs appear distorted, nearly horizontal. No rotation. Both sternoclavicular joints are equidistant from the midline. Distance from the lateral rib margin to the vertebral column are equidistant. Mid-sternum should be at the center of the IR. No motion is evident by the sharp outlines of the rib margins and heart borders. Evaluate AP lordotic chest number 1. Evaluating AP lordotic chest number 1. Analysis. The lung fields demonstrate excessive foreshortening and the individual ribs cannot be identified. They're almost going backwards, like upside down. Correction. If the patient's back was arched, to obtain this projection, decrease the amount of arch until the mid-coronal plane and the CR form a 45-degree angle. If this examination was obtained with a cephalic CR angulation, decrease the degree of angulation until the mid-coronal plane and CR form a 45-degree angle. Chest, PA oblique projection, right and left anterior oblique position. Chest, PA oblique projection, right anterior oblique positions. A 45-degree PA oblique REO projection with accurate positioning, and a proper positioning for a PA oblique REO chest projection are seen here. Chest oblique projection, right and left anterior oblique positions. Both lungs from the apices to costophrenic angles are included within the exposure field. At least 10 posterior ribs are visualized above the diaphragm. Twice as much lung is demonstrated on one side of the thoracic vertebrae than the other side for good positioning, as C joints are air-filled trachea and principal bronchi are demonstrated within the spinal superimposition. Rotate the patient the direction to demonstrate the lung of interest, aligning the midcoronal plane 45 degrees to the IR. The REO, heart shadow without spinal and superimposition. The LEO, heart shadow will partially superimpose the spine. A 60-degree LEO will visualize the heart. The manubrium is superimposed by T4. 1 inch of the apical lung is visible above the clavicles. The humeri or their soft tissue do not superimpose the lung field. So flex the arm closest to the IR so the back of the hand is on the hip. Raise the opposite arm and rest it on the head or upright IR. Excessive chest obliquity. If the desired 45-degree obliquity is not obtained on the PA oblique chest, compare the amount of the lung field demonstrated on both sides to the thoracic vertebrae. If the projection demonstrates more than twice the lung field on the one side of the thoracic vertebrae as the other side, the patient was rotated more than 45 degrees, as seen here in this image. Insufficient chest obliquity. If less than the lung field is demonstrated on one side of the thoracic vertebrae as the opposite side of the PA oblique chest projection, the patient was not rotated enough, as seen here in the image. Evaluate this 45-degree PA oblique LEO chest number 1. Evaluating this 45-degree PA oblique LEO chest number 1. Analysis. Less than twice as much of the lung is demonstrated on the right side of the chest than the left. The vertebral column superimposes the left SC joint, trachea, principal bronchi, and heart shadow. The patient was rotated less than 45 degrees. Correction. Increase the degree of rotation until the midcoronal plane forms a 45-degree angle with the IR. Chest, AP or PA projection, right or left lateral decubitus position. Chest, AP or PA projection, right or left lateral decubitus position. AP, right lateral decube, chest projection with accurate position and proper patient positioning. Chest, AP or PA projection, right or left lateral decube position, evaluation criteria. Both lungs from apices to costophrenic angles are included within the exposure field. T7 is in the center of the exposure field. At least 9 posterior ribs should be visualized above the diaphragm. No rotation. The lung field symmetry should be demonstrated. Distances from the vertebral column to the sternal clavicular ends are equal. The lengths of the right and left corresponding posterior ribs are equal. Lateral aspects of the clavicles are protracted upwards, the arms above the head. Arms, lateral borders of the scapula and mandible are situated outside the lung field. The manubrium is superimposed by T4. The thoracic vertebrae and posterior ribs are seen through the heart and mediastinal structures. An arrow or word marker that identifies the side of the patient that is positioned up and away from the imaging table and/or cart. The lung field adjacent to the table and/or cart is demonstrated without superimposition of the imaging table pad or cart pad. Cart pad artifact. A right lateral decube chest projection demonstrating the cart artifact and the right arm not elevated above the head. Determining side placement downward for APPA decubitus chest positioning. A pneumothorax. Positioning the affected side of the thorax away from the imaging table or cart so the air rises to the highest level in the pleural cavity. For pleural effusion, positioning the affected side against the imaging table or cart. The positioning allows the fluid to gravitate to the lowest level of the pleural cavity, away from the mediastinal structures. Scapula and clavicles. The lateral borders of the scapula are drawn away from the lung field when the arms are positioned up above the head. The position also draws the lateral ends of the clavicles superiorly. If the arms are not positioned in this manner, the arms and the lateral borders of the scapula are demonstrated within the upper lung field. Evaluate decubitus chest, PA left lateral number 1. Evaluating decubitus chest, PA left lateral 1. Analysis. The right sternoclavicular end is situated farther from the vertebral column than the left. The posterior ribs on the right demonstrate the greater length. The patient's right thorax was rotated away from the IR. Correction. Rotate the patient's right side towards the IR until the midcoronal plane is aligned parallel with the IR. Evaluate this image. That's right, there actually wasn't a decube. This is the correct way to display this image. It is an upright chest x-ray. It just has fluid in the right lung. Evaluate this image. There is no marker, however, this is a left lateral decube. This is showing a fluid level on the left side of the lung, down on the bottom, and it is a left empyema. Case study number 1, a 37-year-old male, history shot in the shoulder 3 months ago. Indication he is now having chest pain. The importance of having two views 90 degrees from each other. The bullet is actually superficial, seen here.